Good morning. I'd like to thank the Program Committee of SAGES for the opportunity to present our work. My name is Lilli Schussler, and I'm a second-year medical student at the Icahn School of Medicine at Mount Sinai. I have nothing to disclose. Chronic kidney disease affects almost 10 million people in the US today. Recent data from UNOS found that there are over 94,000 patients on the kidney transplant waitlist, with an average wait time of 3 to 5 years. In 2018, only 21% of patients on the waitlist actually received a kidney. The annual mortality of waitlisted patients is 5%, and the 5-year survival of all patients on dialysis is 35%. To expand the donor pool, donors with comorbid conditions such as obesity and hypertension who were previously excluded are now being considered. Our current policy accepts donors with a BMI of 35. We also accept well-controlled hypertension on one medication in patients over 40. Hypertension and diabetes are the top 2 causes of end-stage renal disease in the US. Given the risks associated with obesity, the aim of this study was to assess whether obesity, classified as BMI greater than 30, is associated with decreased renal function post-donation. We performed a retrospective analysis of patients who underwent donor nephrectomy at Mount Sinai from January 2014 to October 2015. Our donor study group was divided into 2 groups according to preoperative BMI. Group 1 with patients of BMI less than 30 and Group 2 with patients of BMI greater than 30. Demographics, perioperative data, and 30-day mortality and morbidity were recorded. Donors were followed up at 6, 12, and 24 months post-nephrectomy. Renal function was assessed using creatinine. Data was summarized as mean plus or minus standard deviation. Data that included continuous variables was summarized as median. 2 independent sample t-tests, or the Wilcoxon rank sum test, was used to compare continuous variables. Chi-square, or Fisher's exact tests, were used to compare categorical variables. We also compared the trajectories of the obese versus non-obese donor groups over time using mixed effects models. We analyzed the data using SAS version 9.4 with a type 1 error rate of 0.05. This table shows the demographics of our study groups. There were no significant differences in age or gender distribution between the obese and non-obese donor groups. When comparing the associated comorbidities, including rate of hypertension and smoking history, no significant difference was found between the 2 groups. There was no significant difference in race between the 2 groups. All cases were either performed laparoscopically or in 9 cases with robotic assistance. There were 4 donor surgeons, 2 general surgeons, 1 urologist, and 1 transplant surgeon. The use of robotic procedure was offered by the urologist and determined by patient preference. In all cases, 3 to 5 trocars were used. The procedure was performed using a 30-degree laparoscope with the patient in the lateral decubitus position. This table compares the perioperative data of the 2 study groups. The operative time was significantly longer in obese patients with a p-value of 0.03. There were no significant differences in intraoperative fluids, estimated blood loss, or intraoperative urine output. The left kidney was the preferred side in both groups. No conversion to open surgery was seen in both obese and non-obese donor groups. The median length of stay was 2 days in the non-obese group and 3 days in the obese group, and this difference was not statistically significant. There was no incidence of venous thromboembolism or urinary tract infection in both groups. There were no significant differences in any morbidities, including persistent pain, hematoma or seroma, wound infection, and depression. There was 1 readmission that occurred. This was a non-obese patient who was readmitted for pain. This graph shows the creatinine levels of both groups over time. As you can see, there is an initial increase in the creatinine levels in both groups post-nephrectomy. The increase in creatinine was not statistically significant between both groups. This graph further illustrates the change in the trajectories of the creatinine levels of both obese and non-obese donor groups. The baseline creatinine was significantly different between the two groups, with a p-value of 0.02, but the creatinine level was not significantly different at 6, 12, and 24 months follow-up. The creatinine level in both groups began to decrease towards baseline with time. The difference between the trajectories of the obese versus non-obese groups was not statistically significant overall. Our results showed that there was no significant difference in the post-operative creatinine levels of obese donors compared to non-obese donors undergoing donor nephrectomy. In our study, patients with BMI greater than 30 did not have decreased post-operative renal function. Operative time in the obese group was 18 minutes longer, and this difference was statistically significant. But 30-day morbidity and mortality were not significantly different between the two groups. Donor nephrectomy was safe in obese patients. Our results raise further questions and further directions for research. For instance, what happens to donors who lost weight to meet the BMI cutoff of 35? Some of our kidney donors have had bariatric surgery. How do they fare long-term? To this end, we are conducting a study of long-term donor follow-up to determine the rate of weight regain, development of diabetes, hypertension, and renal insufficiency. There has been no increase in graft complications or adverse effect on graft function since the inclusion of obese donors, but graft survival and recipient renal function will also be reported. I would like to acknowledge my research mentor, Dr. Edward Chin, our biostatistician, Prerna Ketan, and the Rekanati Miller Transplantation Institute for data collection. Thank you.